It's my really great joy. I got to know Leo a couple of years ago when I was the co-chair of the scientific committee of the International Society of Travel Medicine. I'll give them a plug. Our past president, Leo Visser, and also Lynn Chen's on this call, I see. I really got to see what a kind, gentle soul you are, but you're a rock star in your world also. So let me let you know a little bit about Professor Visser. Professor Visser. So Professor Leo Visser studied medicine at the University of Leuven in Belgium. He specialized in infectious disease at the Leiden University Medical Center, where he's really made his career. He also has obtained his Ph.D. there also. He was appointed professor in infectious diseases and travel medicine. I didn't realize you could do that. For many years, he is involved in, as I said to you earlier, clinical care, research, teaching. I think he's really training the next generation of clinicians. And this is in internal medicine, infectious disease. And he has a real passion for vaccinology, vaccine preventable and tropical diseases, where he really is considered a leading expert. He is the head of the Leiden University Medical Center Travel Clinic. He also is head of the Department of Infectious Diseases there. They serve as a regional center in Belgium. He holds many different leadership positions, but I will mention he's the past president of the International Society of Travel Medicine, where he has had huge impact, and he has mentored many young clinicians. His current research activities involve the safety and immunogenicity of alternative vaccination routes and vaccine responses in the more vulnerable individuals with chronic diseases, advanced age, or immunosuppression. I will be sending you an article that he authored, but he is the lead author on the Annals of Internal Medicine article on long-term protection of after fractional dose yellow fever vaccine. And many of you know that there have been a lot of yellow fever outbreaks, leaving us with depletion of yellow fever vaccine. So I think he's a great example of how one can marry science to travel medicine. He's made an incredible career and remain a clinician. So for that, I want to thank you, Leo. And I've heard your talks before. They're amazing. So fasten your safety belts, everyone. You're in for a real treat. So Leo, welcome.
Thank you. Thank you very much. I will share my screen.
I'll stay on until your slides come up and let you know when
yes.
they're on. Okay, we can see them, Leo. So I'm gonna.
So now I'll make it like that. Perfect. And my mic is on as well. So make sure that you can.
We can hear you.
Yes.
We can hear you well. Thanks,
Perfect.
Leo.
Okay. So for this presentation, I do not have any conflicts to disclose. And actually, I would like to thank Chris for the invitation and the very, very kind words. What I would like to do in the next hour is to provide you with some conceptual toolboxes you can use to approach a traveler who receives treatment for autoinflammatory disease or solid organ transplantation. And then try to give you some tools to answer the question, how will this affect his immune response to a vaccine? What does it do to his susceptibility to particular pathogens, and how to prepare this person best as we can? It must be said that there's a lot that is actually not well known. So that's the reason why I really want to provide these toolbox to you, because then you have your own way of trying to think what the best solutions are. So the lecture will consist of two parts, and the first part will address the questions around vaccines, and the second part will then address the questions around the susceptibility to pathogens and infectious diseases. So for the first part, I would like to have the next approach. So I will discuss shortly what the basic principles are in the immune response to a vaccine. Then we will look into more detail on the different actions of disease-modifying immunosuppressive drugs, and give you some examples how these drugs can affect vaccine responses. And at this point, I will illustrate this also with the recent research on COVID vaccines, because actually there's been a lot of research on vaccine responses and these immunosuppressive drugs, much more than there is for travel-related vaccines. And finally, I will close this part of the presentation with some rules of thumb. Now, besides the emotional stress that is caused by an injection, the injection of a vaccine also induces small tissue injury and some inflammation at the site of injection. And this attracts specialized cells that will eat up the vaccine antigen, break it down into small pieces of about 10 amino acids, and these peptides are then presented to the T and B cells in specialized areas. Now, these specialized cells are called antigen-presenting cells or dendritic cells, and they are a type of macrophage. And for inactivated vaccines, most of the immune response will actually occur or be mounted at the draining lymph nodes in the axillary region. Whereas for live attenuated vaccines, the whole lymphoid system and spleen are involved in the immune response that will follow after the injection. Before a T cell and B cell activation can actually take place, the dendritic cell has to tell the T cell that what he is presenting is actually something which is bad news. This is done by producing a co-stimulatory signal, and that could be part of the vaccine itself, but most often it's the adjuvant that is a substance, a chemical that is added to the vaccine, or a natural product that is added to the vaccine that actually provides that second signal, which tells the T cell or the B cell that it has to respond to this particular peptide that is being presented. Now, dendritic cells have specific receptors that actually are designed to recognize conserved molecular patterns of pathogens like bacteria or viruses. It's a kind like a smoke detector, where you have smoke detectors on the outside, which can recognize bacteria or bacterial substances from bacteria, but you also have smoke detectors on the inside in the endosome, which will recognize, for example, viral RNA or viral DNA. And finally, you have receptors within the cytosol, the plasma of the cell, which will recognize mainly, for example, damage to the cell, and will create what is called a kind of small complex of proteins, the inflammasome, which in its turn will provide the necessary stimulation. And in bold, you can see here different type of adjuvants. Of course, the cytosolic element is the most frequently used, but currently we have also AS01 and AS04, which are present in a number of vaccines that are used and which can provide the necessary co-stimulatory signal. So we have our antigen presenting cell. It has picked up the antigen, it has broken it down to small pieces, present them to the T and the B cells in the lymph node, and then it tells the lymph node or the T cell that this is bad news, and it uses smoke detectors on the outside and the inside of the cell to recognize those components, and this signal is provided by the adjuvant of the vaccine. You have to realize that for each antigen, we only have a handful of T cells and B cells that are able to recognize it. So in itself, these numbers are much too low to mount an effective immune response. So to have an effective immune response, this number of cells need to increase a 1,000-fold or even 100,000-fold to be effective. In itself, this is a way to protect ourselves against autoimmune responses. And in addition, it's also, from evolutionary standpoint, very efficient, because the things you don't have to react to, you don't have to waste any energy to build cells. So at the moment that the vaccine has been administered to a person, there is only a handful of T cells that are able to recognize the peptide that's been presented by the antigen presenting cell with the co-stimulatory signal, the signal 2. But upon recognition, there is a binding and activation of a number of enzymes, which will result finally in the transcription of a number of genes in a nucleus, and on their turn will result in the expression of interleukin-2 receptors and the production of interleukin-2, which will drive the final signal, signal 3, and result in activation of the cell cycle, which then results in a clonal expansion of the T cells that can recognize this particular antigen. So from a handful to 10,000, 100,000 of cells. And as soon as the pathogen has been cleared or the vaccine response has been made, this number will go down again, because it's, again, not necessary to keep it in a high number, but there will also be memory cells that can be redressed upon re-exposure to the vaccine antigen. So it isn't a surprise that most of the drugs we use for immunosuppression actually prevent this clonal expansion. It is as if you are hitting the brakes in this clonal expansion process. And from left to right, you can see that, for example, cyclosporin, tacrolimus, they inhibit the calcineurin pathway. Corticosteroids, they block NF-kappa beta. They provide actually inhibitors to NF-kappa beta. Belatacept and abatacept, they block the second signal, and therefore the co-stimulatory signal required for activation. Everolimus and sirolimus will block mTOR. Mycophenolic acid and leflunomide will interfere with nucleotide synthesis. Alemtuzumab will actually kill the T cell, and the thiopurines and methotrexate will interfere directly with the cell cycle. But the end result is that the number of T cells that are activated by exposure to the antigen and the co-stimulatory signal, that number is severely reduced. A very similar process takes place for the B cell. So the B cell will recognize the antigen by its antibody receptor, which is on the surface of the cell, either being presented by a dendritic cell, or after digestion by the B cell itself, and then presenting it to a T cell for the acquirement of T cell help. So upon activation, very similar to the T cell, there will be a clonal proliferation of B cells that are able to recognize the antigen that is being presented by the dendritic cell, or that is bound to the receptor of the primed B cell. And already very early on, about around day 5 to day 7, the first effector cells that are short-lived plasma cells, they are producing IgM antibodies, and also memory cells are formed. But actually, most of these cells that are activated will move to a specific area of the lymph node, which is called the germinal center, where again, an intense proliferation takes place. But during that proliferation, small mistakes are made, and therefore the antigen binding part of the antibody has slight differences between the different cells. And only those antibodies that bind best to the antigen will survive the selection process that follows. And with help from the T follicular helper cell, they will then differentiate further to long-lived plasma cells, which can live for 10, 20 years and produce antibodies all the time, and memory B cells. The difference between the day 7, when we have our first short-lived plasma cells and the first antibodies, and day 10 to 42, where we have our long-lived plasma cells, is that the antibody quality of those long-lived plasma cells is much, much better, with high affinity antibodies that are much more able to inactivate and to neutralize opsonize the pathogens. After exposure or after vaccination, you have an antibodies are rising, and you have an increase in number of T cells and B cells, and you are producing antibody levels, but in due time, those antibody levels start to wane again until a new exposure to a vaccine antigen or a pathogen. The difference between the first vaccination and the second vaccination is that on the second vaccination, we have memory. So we have memory T cells and we have memory B cells. The numbers of those cells are already higher than before vaccination. So it's a 10 to 1,000-fold more cells. And in addition, they require less of activation to be to start up the whole process again with clonal expansion and further differentiation. So what you will see is a very rapid increase in numbers of cells and in antibody levels. And again, the same process of proliferation, hypermutations or somatic hypermutation, and then selective, so taking out those antibodies that are having the highest affinity will finally result that the second antibody response, the antibody affinity and the quality of those antibodies is better than the first response. The interval between the first vaccination and the second vaccination, the shorter it becomes, the more the second vaccination is going to interfere with the memory formation of the first response. So making the interval shorter actually is less beneficial for the long-term immunity than spreading the dose further away so that you have more time to develop a good memory response after the first injection. Because clonal expansion, both for T cells and B cells, is essential, and because the primary immune response to the first vaccination, you start with a very low number of cells that are inadequate for an effective response. It makes sense that all immunosuppressive drugs have a more profound influence on the primary immune response to a new vaccine than to a secondary immune response or a booster response to revaccination. Because in the second circumstance, you already have much more cells, they are more ready to respond, and you can expect more frequently to see an antibody response, although it may be lower than in non-immunosuppressed individuals. So let's have a look at the different drugs we have and that are used for the treatment of all types of auto-inflammatory diseases or for solid organ transplantation. First of all, we have classes, they are called the anti-integrins, which interfere with the homing in of T cells into specific areas or specific tissues. So for example, for inflammatory bowel disease, there are specific anti-integrins that interfere with the homing of T cells into the intestinal mucosa, and therefore the inflammatory response in the intestinal mucosa is reduced. The next class is the cytokine and the Janus kinase inhibitors. The third class is the clonal expansion inhibitors. And finally, we have the cell-depleting biologicals and drugs. And you can see the different phases in where the effect of these drugs is most profound. You can imagine that if you just kill all the cells, and so the number of T cells and B cells are quite low, then of course this will affect mostly the last step of the response to the vaccination. So let's have a look into more detail for the different classes. First of all, we have the biologicals and the Janus kinase inhibitors, or the JAK inhibitors. So immune cells, so T cells, B cells, dendritic cells are talking to each other using small molecules, which are called cytokines. And that's in the upper left of this slide. Those cytokines bind to a receptor, and then this results in the activation or with the help of the activation and of the Janus kinase proteins, which then will send a message to the nucleus for the transcription of the target genes, which then result in the final response of the cell. So you can block this talking between cells, or you can silence the signals by using antibodies that actually bind to the cytokine or bind to the receptor. This is shown on the left, on the bottom of the slide. Or you can use blockers of the Janus kinase. The difference is that in the first part, you have to inject those antibodies, whereas the Janus kinase inhibitors are drugs you can take by tablets, and therefore they are much more easily to use. As you can see on the right-hand slide, there are it's a large number of different Janus kinase types of receptors, and they all have their very specific effect depicted in gray. At the moment, most of the drugs are non-selective. That's on the bottom in light blue, like so you can see on the bottom. And but in the future, it is expected that we will see more and more selective Janus kinase inhibitors with a very specific effect on specific functions of the immune system. For example, some of those inhibitors will affect the anti-inflammatory response, but also the antiviral response. And therefore, the individual using these drugs will be more susceptible to viral infections, but also it will be more difficult to respond to vaccines because they will interfere with the signaling between the different immune cells. We already showed this picture before, where we see the different immunosuppressive drugs inhibiting the clonal expansion. And as I said, this is like driving with the brakes on. On one hand, you are accelerating because you're trying to stimulate the cell with a vaccine and a co-stimulatory signal. But on the other hand, you're putting the brake on because you're blocking the cell cycle. The drugs do have a different level of braking. So the mTOR inhibitors are the least immunosuppressive drugs, whereas the calcineurin inhibitors and then the anti-metabolites have a moderate inhibitory effect, whereas the mycophenolate acid and derivatives have the highest immunosuppressive effect. So for mTOR inhibitors, you can sometimes see a primary response, and you will see a good secondary response. For calcineurin inhibitors and anti-metabolites, you will see a reduced to almost absent primary response and a reduced secondary response. And for mycophenolic acid and derivatives, you will see no primary response or almost none, and often also no secondary response to the second vaccine. So mycophenolic acid is really a very profound inhibitor of the clonal expansion. The brakes are completely on. So just to give you a picture on how this looks like in numbers. So if you block clonal expansion, then the number of T cells, and it's on the right-hand side of the picture, the number of T cells is reduced, but also the number of B cells is reduced. And as a result, not only those T cells are less able to provide help or kill virally infected cells, but also the number of plasma cells that are formed is reduced, and then the levels of antibodies will be lower and they will wane much sooner. And also the number of memory cells is reduced, meaning that on re-exposure, the memory response will be less than in a person or an individual that does not receive immunosuppressive drugs. And finally, we have the cell-depleting immunobiologicals, like, for example, the drugs that have anti-CD20 or anti-CD19, which will kill all naive germinal center and memory B cells. And then, of course, if you try to vaccinate somebody to induce an antibody response, that's like knocking at the door where nobody is at home. It's an empty house. There will be no response to be expected. And for primary responses, this will last until 12 months after the administration, whereas for the secondary response, so revaccination, this will last up to 6 months after the last administration of the drug. So let's have a look on how this translates into travel-related vaccines. So on the left-hand side, you see the pooled seroconversion rates 4 to 8 weeks after the first dose of an Hep A vaccine. So that's the primary response for different classes of drugs, from above to below TNF-alpha inhibitors, the conventional immunomodulators like methotrexate, then the organ transplant recipients, and finally the healthy controls. And of course, after the first dose, healthy controls will almost always, up to 90%, have a seroconversion. Whereas for the immunosuppressive drugs, only with the conventional immunomodulators, some of the individuals will have a response, but many will not have a seroconversion response. In TNF-alpha inhibitors, it is around 40%. But when you give the second dose, and so when you address the memory response, you see quite a different picture. For the healthy controls, of course, you have a slight increase, but for the TNF inhibitors, the second dose will result in almost 80% seroconversion rate. And for the conventional immunomodulators, it really depends on the type of drug, but it amounts to around 70 to even 100%. For the organ transplant recipients, it really depends whether mycophenolate mofetil or mycophenolate derivatives are involved. And there the antibody response is much more reduced. So from this slide, you can conclude that for most travelers that are, if you have time, it is worthwhile to provide 2 doses of Hep A vaccine before they travel, to make sure that most of them will seroconvert. And the only category where we do still see problems with 2 doses are the organ transplant recipients. I don't know how it is in the States, but we are still fortunate that we have immunoglobulins we can give, which contains enough antibodies against Hep A. So these travelers then will receive passive immunization with immunoglobulins which will protect them for 6 to 8 weeks travel. Just to illustrate what I discussed before, I would like also to show you some results from recent COVID vaccination studies. And this is in patients with inflammatory bowel disease, where you can see the difference in antibody response between an anti-integrin, which is depicted in orange, and a TNF inhibitor. This is the first dose. And you can see that the anti-integrins actually do interfere much less than the anti-TNF inhibitors in the antibody response to the spike protein. Recently, also, a study of 2 cohorts of patients with autoinflammatory diseases and autoimmune diseases was presented. Most of them had rheumatoid arthritis and were receiving different combinations of drug depicted on the left hand side of this slide. And what you can see is that seroconversion, so on the left hand side, you can see the healthy controls and the individuals that were not taking immunosuppressive therapy. And it seems that having rheumatoid arthritis by itself does not interfere with the antibody response to vaccination. Then you can see there's a slight decrease with the individuals that were on TNF inhibitor monotherapy, but especially for the group that received methotrexate and anti-CD20 treatment, the antibody response after the first dose was significantly less than compared to the control group and the other patient groups. Then it's important to note that after the second vaccination, actually all individuals, although the numbers are much smaller, did have a good response, except for patients that were on anti-CD20 therapy. And from a conceptual view, you can understand this, because again, if the house is empty, there will be no response. There are no cells to respond, so you cannot expect these individuals to respond with an antibody response. And finally, in this study, the likelihood of seroconversion did not differ between an adenovirus platform vaccine or a mRNA vaccine. And finally, this is a publication from the New England you are well aware of, and it shows you patients with this is a retrospective study of 101 solid organ transplant recipients, showing that after 2 doses of mRNA vaccine, the antibody response was very poor, and only 30%, around 30%, responded with a seroconversion. And it must be said that this antibody test was a very sensitive one-time test. So already low levels of antibodies are detected in this assay. So it is a little bit flattered definition of seroconversion. And finally, a third dose did show a further increase in a number of individuals that seroconverted. And I think this is the basis for the policy that individuals on solid organ transplant recipients are going to receive a third dose to boost their memory cells further. It must be said that still, in this study, at least 30% of the individuals did not have antibody or did not seroconvert. So even after a third dose, there will be still a population that will not be protected by vaccination. And that's important to realize in travelers that are going to travel to areas where they may be exposed to COVID. So to wrap up for this first part, I would like to ask you specific attention for this very comprehensive review of the EULAR, the European Association for Rheumatology, which reviewed the guidelines for vaccination of adult patients with autoinflammatory diseases. I think I want to ask your attention for, or draw your attention for 2 points, I think, which are very important. First of all, that, of course, don't forget that influenza is also a travel-related disease, and yearly influenza vaccination is strongly recommended. And secondly, I want to draw your attention to point 4, that in individuals that travelers who did not receive a second MMR vaccine, that in several situations it is safe to provide a second dose and to boost their immunity. But you have to be, of course, in the cell-depleting immunotherapy where you kill all your B cells or T cells. This is not a safe way, but in other circumstances, it has been shown that it is safe to provide a MMR booster without any side effect. It results in boosting your immunity, and it will provide protection against measles, which, as you know, is recurring in many areas in the world. So the rules of thumb: ideally, of course, vaccinations should be given before or at the lowest level of immunosuppression. And we try to see patients that are going to receive a solid organ transplantation before they travel or before they receive the transplant, and then already discuss with them what their traveling ideas are and whether or not they, for example, would require yellow fever vaccination in the future. And some of them will receive yellow fever vaccination before they have their transplantation. Live attenuated vaccines should be avoided. MMR can be used MMR booster can be used under special circumstances. All immunosuppressive drugs will affect primary response to a new vaccine more than a secondary response to revaccination. And after cell-deleting treatment, memory B cells, plasma cells, and antibody responses will be impaired. And that can be last up to, depending on whether it's a primary vaccination or a secondary revaccination, can last up to 12 months. In the second part, I will have a similar approach as in the first part. I will discuss first the principal immune responses to pathogens, and then again review the different actions of the disease-modifying drugs. But now you already have seen most of those drugs, and as a kind, it's a kind of fresh up of those of the former presentation. And then I will give you some examples of the effects of these drugs on the susceptibility to infections, and finally again how to approach the traveler. Now, for the immune system, the world of pathogens can be classified into 3 classes. On the microscopic level, you have the extracellular pathogens, and you can see here bacteria on the bottom low with an arrow indicated. These are pneumococci in a patient without spleen who has a pneumococcal sepsis. The second class are the intercellular pathogens, as shown here, a macrophage full of mastigotes of Leishmania, and finally the helminths on the right-hand side. So these are large organisms you can see almost see with the naked eye, like the larvae of Strongyloides. So just to give you some examples of those pathogens, we have the strep pneumonia already discussed, but also Campylobacter is an example of an extracellular pathogen. The intracellular pathogens you also know very well, like Legionella or Salmonella and Mycobacterium tuberculosis, but also Leishmania, Cryptococcus, Cryptosporidium are examples. And finally, measles and influenza, noro and papillomavirus needs to be discussed. And finally, for the helminths, actually, there's only one species which is important. This is Strongyloides stercoralis, because this is a helminth, a geohelminth infection that can persist lifelong, and even years after travel to the tropics can reactivate under immune suppression and cause a life-threatening disease. And therefore, it is important to know this particular helminth. As I said, for the immune system, there actually are 3 classes. And for each of these classes, we have very specialized cells that can respond to the presence of these cells in the tissues. So the moment that there's tissue invasion by the intercellular pathogen, this is recognized by natural killer cells and the innate lymphoid cell type 1. And these will produce cytokines to talk to not only macrophages to activate them, but also to help the epithelial cells to defend themselves against these intracellular pathogens. And this response is called a type 1 response. And very similarly, we have innate lymphoid cells type 2, which will, for example, induce mucus production in the intestine to try to clear off the helminths, but also will provide additional cytokines to the macrophages to activate the macrophages and the dendritic cells. And this results in the type 2 response. And finally, for the extracellular, we have the type 3 response. We already know our antigen-presenting cell or dendritic cell, and very similar to when exposed to a vaccine antigen, the dendritic cell will bind to the pathogen, be it a virus or a bacterium. It will degrade this bacterium to small pieces and then present these pieces to the T and B cells in the lymph nodes, and then to activate those cells to induce an adaptive immune response. And as discussed before, this dendritic cell has smoke detectors on the outside, which specifically recognize extracellular pathogens like bacteria, but also fungi and helminths. And it has intracellular smoke detectors, which will recognize viral particles, and for example, viral intracellular bacteria, which will activate other types of immune cells. So each specific activation will guide the T cell to make a very specific response against the intercellular pathogen, type 1 response, to the extracellular pathogen, a type 3 response, or to the helminth, which is a type 2 response. And very similar to the vaccination again, upon presentation of parts of the pathogen in combination with the co-stimulatory signal, we will have a clonal expansion of T cells, and we will have a clonal expansion of B cells with the formation of long-lived plasma cells, which are producing antibodies, which will help clear the pathogen, and also memory cells for future re-exposure. And so the end result is then the clearance of the pathogen. So for the type 3 response with the extracellular pathogen, T helper 17 cells will produce cytokines, for example, like IL-17, which will attract neutrophils to the site of infection. And these neutrophils will be activated and they will chew up the pathogens that are present at the site of infection, aided by antibodies that will make them more attractive to consume. The type 1 response, the type helper, the T helper 1 cells will produce interferon gamma and TNF alpha, which will help the macrophages to kill intracellular pathogens like Mycobacterium tuberculosis. And these dendritic cells will also provide expose the necessary antigens to the T cells to make antibodies. And finally, we have the type 2 response with type 2 helper T cells, which produce IL-5, which will attract eosinophils, and IL-4, which will induce the formation of IgE. And these cells will actually degranulate and then and will try to damage the helminth and kill the helminth, and the M2 macrophages then will come in for tissue repair. So there's continuous crosstalk between the adaptive immune response with T and B cells and the innate immune response with neutrophils, with macrophages, eosinophils, and this crosstalk is happening with all types of cytokines. So let's go into more detail what this means for the traveler, and when you have a traveler who comes with an immune suppressive disease to your clinic. It's important to realize that the first barrier against infection is actually your skin and your mucosal epithelium. So you always have to ask yourself, is the integrity of the barriers, or are the barriers intact? Is the integrity all right? So for example, if somebody is taking corticosteroids, the skin thickness may be reduced. It may be more prone to blisters or bruising or tears, and therefore that person is more at risk for wound infections with Staph aureus or Strep pyogenes. Very similarly, if there is continuous inflammation and congestion of the upper respiratory tract, then of course there may be more difficulty in clearance of pathogens like pneumococci or Haemophilus influenzae or influenza, and this will result in upper and lower respiratory tract infections. The use of proton pump inhibitors will block gastric acidity and increase the susceptibility to foodborne infections, as it will reduce the infective dose 100 to 1,000-fold. The use of antibiotics will interfere with the microbiome of the gut and will aid with the colonization of multi-resistant gram-negatives, which may be a problem upon return to your clinic when they present with high fever and a urinary tract infection. It might be that it is a multi-resistant strain they have acquired from abroad. And finally, especially, for example, in kidney transplant patients or patients with diabetes, urinary tract infections may be a problem as well. As I already presented before, there is a continuous crosstalk between the adaptive immune cells, like the T cells, and then the innate cells. And so if you have a drug that actually interferes with TNF, then it will affect the type 1 response, and it will make a person more susceptible to infections with intracellular pathogens. Whereas if you use IL-17, it will interfere with the attraction of neutrophils, and it will make a person more susceptible to a type 3 response. And so you can actually put that in a table. We already discussed the different biologicals that are JAK inhibitors that interfere with the signaling. And then you get a table like this. Anti-IL-1 will have an effect mostly on extracellular pathogens. Anti-IL-6, quite similar. Anti-TNF will have the most profound effect on the intercellular pathogens, as anti-IL-12. And anti-IL-5 may have an influence on strongyloides. It has not been reported yet, but you can actually imagine that it may have an effect on this pathogen. We discussed before the different inhibitors of T-cell activation and clonal expansion. And so when you are have an infection with, for example, a viral pathogen, the number of T cells that try to proliferate is inhibited by these drugs. So the immune response against the viral infection will be slower and more delayed. And in the end, there will be less cells to fight that viral infection. So it makes an individual more prone to a prolonged and more severe course of the disease. Similarly, if you kill the T or B cells, you do not have cells to respond, and it also makes an individual more vulnerable. It has to be said that for the cell-depleting immunobiologicals that kill the plasma cells, that kill the B cells, often they do not affect the plasma cells. And as a consequence, the antibody levels are actually determining whether or not a certain person is at risk of infection. As long as the IgG is above 6, the risk of infection is low. So again, with the different classes of immunosuppressive drugs and the different classes of pathogens, you can predict what is going to happen. If you use chemotherapy that is killing your T and B cells or is killing your neutrophils, you'll be much more susceptible to extracellular pathogens. If you're low on antibodies, you'll be more susceptible to extracellular pathogens, especially the capsulated bacteria, pneumococci, Haemophilus influenzae, and the meningococci. If you're using corticosteroids, you are more prone to infections with intercellular pathogens like Salmonella, but you're also prone to severe infections with strongyloides, especially upon return. Calcineurin inhibitors and then the anti-metabolites and MMF mostly interfere with the protection against intercellular pathogens, so it makes you more vulnerable to these pathogens. And finally, for the HIV patients with a low CD4 count, as you know, it's mainly intracellular, but also extracellular, like pneumococci. So what are then the rules of thumb for a practical approach? First of all, again, vaccination should be given before the lowest level of immunosuppression. Secondly, when a traveler is visiting your clinic, you have to assess his general physical condition, because often with, for example, a kidney transplant patient, they have a long-standing history, for example, of diabetes mellitus. And this may have all kinds of effect apart from the, so that can cause all kinds of comorbidities, which have a different approach from the immunosuppression by itself. You have to assess the integrity of the skin and mucosal barriers. Then you have to determine the type and level of immunosuppression, and you have to quantify the increased vulnerability to infections with extracellular and intercellular pathogens. And finally, based on these data, you can specify no-go areas. You can promote risk reduction and provide advice on standby treatment. So let's give you two examples. This is a challenge. This is a person, or this is a travel. It's a 10-day package, eco tour to the rainforest of Colombia, where you can fish piranhas in the Amazon. You can canoe along the Grand Rousse, and finally you can swim in the beach, which is very popular in that area. Now let's take a first example of a traveler. This is a 27-year-old traveler with a common variable immunodeficiency, with a CD4 count of 337 and an IgG4 of 4 grams per liter. He has recurrent upper respiratory tract infections, and he has suffered in the past from Campylobacter enteritis, and he's receiving gamma globulin infusion every month, 20 grams to compensate his low levels immunoglobulins. And he is using a proton pump inhibitor. So taking the rules of thumb in your mind, and then look to the practical approach. First of all, are the barriers, the skin and mucosal barriers intact? So this person has a dysfunctional respiratory mucosa with recurrent upper and lower respiratory tract infection. And because of the low level of antibodies, this is very specifically for pneumococci, Haemophilus influenzae mostly. And therefore, standby antibiotic treatment, which is directed against these pathogens, is in its place. He's also using a proton pump inhibitor. Very often, this is not actually, most people do it because of digestion problems. And so the indication for a proton pump inhibitor is often not that pronounced, so that strong. So often it's possible to interrupt the proton pump inhibitor treatment and take it with you as a kind of standby in case of, and most people actually don't need it during their travel. And it increases your protection against foodborne infections. This particular traveler is low in IgG, making him more susceptible to encapsulated bacteria. And besides the standby antibiotic treatment, he will receive an additional gamma globulin infusion just before travel. He is also low in IgA, which makes him more susceptible to Campylobacter infections. And therefore, because of this vulnerability, the antibiotic treatment against traveler-related diarrhea should be a macrolide to counter the Campylobacter infection. And one should be aware of colonization of the intestine with extended spectrum beta-lactamase producing gram-negatives upon return. And in case of fever or sepsis, in the first months after return, one should take this into account. And finally, a CD4 count of 337 increases his risk to intercellular pathogens like Salmonella, Histoplasma, and maybe HPV. And so riskful exposure should be avoided, and I'll come back to that later. A second example, same travel, but now a 72-year-old traveler with a second kidney transplant last year. And he had a conditioning therapy with alemtuzumab. Afterwards, there were no rejection therapy, and it's receiving prednisone, tacrolimus, and mycophenolic acid. For his hypertension, he is on diuretics and ACE inhibitors. And because of his diabetes, he has distal sensory neuropathy. So again, if you look at the practical approach, the integrity of the barriers, he has a sensory neuropathy, which puts him at risk of having blisters on his feet and increased risk of S. aureus and strep pyogenes infections. So proper footwear in this particular traveler is of essential importance, with the frequent inspection of his foot, really high attention to the proper foot care, and standby antibiotics may be considered directed against Staph aureus and strep pyogenes. There may be difficulty with bladder function and dysuria, maybe also a neurogenic bladder dysfunction. And in case of urinary tract infections, especially upon return, if a transplant patient comes back after travel to the tropics with a urinary tract infection, one should be aware of the colonization with multi-resistant bacteria after return. Because of his old age, there's also immunosenescence, which puts him at more risk for respiratory tract infections like with pneumococci and influenza, and vaccination is recommended. The alemtuzumab actually will last, its effect will last for 12 months or more, and make him more prone for intercellular pathogens. And so we have to avoid riskful exposures. There will be certainly no-go areas. And finally, the anti-immunosuppressive drugs will block clonal expansion and again make him susceptible to intercellular pathogens like Salmonella. For prednisone, in case of fever during travel, the dose should be doubled. For the Salmonella, a standby treatment with azithromycin, again, is the drug that has the least interference with the calcineurin inhibitors, and is an adequate treatment for Salmonella. And sun blocking cream is also important to reduce the chances of papillomavirus infections of the skin and skin cancer in future. So what I already said, we have to avoid exposure or exposure to certain risks. So avoid exposure to surface water, being sweet water or salt water, because of the risk of Giardia lamblia, Cryptosporidium, Cyclospora, or in salt water, Vibrio vulnificus, norovirus, and enterovirus, especially when you're swimming very close to a sewage pipe which is releasing its sewage into the swimming pool or the swimming area. Of course, safe food and beverage precautions, no undercooked seafood, meticulous hand hygiene, and interrupt the proton pump inhibitor. In case of diarrhea, especially when the patient is taking the drugs for hypertension, diuretics and ACE inhibitors should be stopped, and the statins also until the diarrhea has disappeared, to prevent dehydration and also to prevent renal shutdown because of these drugs and dehydration. Avoid dust-laden environments, plant and soil aerosols, and bird droppings and caves because of the risk of histoplasmosis and some environmental fungal infections. And finally, use sun-blocking cream and stay in the shade to reduce the risk of cutaneous squamous carcinoma, especially for the younger patients on immunosuppressive drugs, and of very difficult to treat papillomavirus of the skin. And finally, concerning COVID, there are also many no-go areas, especially areas where the health systems can be overwhelmed because a certain surge of COVID. And at the moment, because in many patients, especially the solid organ transplant patients, where the antibody levels are still low, and we still have no good idea about the efficacy of that vaccination, I think it is wise to avoid the very high-risk areas with high prevalence of COVID and low availability of high-quality healthcare. So to finish, the rules of thumb again: ideally, vaccination should be given before or at the lowest level of immunosuppression. Live attenuated vaccines should be avoided, with the possible exception of a cautious use of MMR booster under special circumstances. Please refer to the EULAR guidelines. Immunosuppressive drugs will affect the primary response to a new vaccine much more than a secondary response to revaccination. So the yearly flu shot actually works well in most of them, whereas a new vaccine is much more difficult to have a good response. Memory B cell, plasma cell, and antibody responses to vaccine are most impaired by drugs that interfere with the clonal expansion of the response. And finally, cell-depleting drugs, the effect extends up to 12 months after administration. And for the infections, ideally, again, vaccinations should be given before or at the lowest level of immunosuppression. Assess the general physical condition, the skin and mucosal barriers integrity, determine the type of immunosuppression, quantify the risk to certain infections, be it with extracellular and intercellular, specify the no-go areas, and then promote risk avoiding and provide standby treatment. Thank you for your attention.
Leo, that was masterful, really masterful. Pretty odd. We're at 10:25. You have 5 minutes. I didn't interrupt you because you were right on time. So for the audience, do you have any questions for Professor Visser? I'm looking in the chat. Any questions? Let's just see, and I'm going through. All right. I don't actually see any questions. I'll give them a few more minutes. People are writing fantastic. It really was fantastic. So just a personal question. Are you seeing a lot of travelers right now and especially immunosuppressed travelers? Are they coming to your center?
So not a lot. So we do see some immunosuppressed travelers, but most of them will travel within Europe at the moment because it's easy, no quarantine. And of course, especially because some areas have a really low level of SARS-CoV-2. And I do see some VFRs that are traveling back to their country of origin. And then there's often a discussion about the risk, but as said before by Ed, that people are going home, so there it's a more difficult discussion. Maybe in the future we will come. Hopefully next year we will have a kind of laboratory test where we can actually assess whether somebody is protected or not, and maybe at that point we will also be in the we have the ability to revaccinate people. So these are the two, I think, hopeful that we can have a test where we can say this particular traveler is protected, he can travel. Passive immunization is probably something we cannot afford, and revaccination just before travel, boost those who do not have enough antibodies might also be an option. But I think this is really for the future.
Interesting. One participant is asking your comment about stopping the PPIs.
So your mic is dropping out.
Yeah, I don't think this is working, so I'll have to get close. One participant is asking about dropping the PPIs. Can you hear me?
Yeah. So the dropping the PPIs. So this is what this is my experience, especially in the solid organ transplant patients. Many of those people take a lot of drugs, especially in the first year. And then because of mild discomfort in the stomach, they also are prescribed a proton pump inhibitor. And then, of course, they get used to it, and often it's not stopped. So then, of course, after a year, many of the drugs are reduced, but still they are on proton pump inhibitors. And then it's discussed with the traveler from what is the specific indication. Was it esophagitis? Was it gastric ulcer? What happens if you stop the drug? Do you suffer a lot if you stop? Do you get again your esophagitis back? And many people don't know. They just have discomfort from the drugs they're taking, and then they are using the proton pump inhibitor. So in this particular example, then I would suggest to stop it often already and just try it. You can try it actually at home first, a week if you've supported well, you can do it, and take the drugs with you just in case that if it comes back, you can actually start it up again. I always discuss it with the treating physician whether there's any objection. For example, again, if it would affect the drug-drug interaction, and then certainly some and drug levels would rise because you're stopping some medication. But for the kidney transplant, this is has never been a problem. And many of our travelers actually can stop the drug without problem. Yeah.
Okay, great. I'm going to keep us on time. It's actually 10:29. And we're really almost at time. So Leo, thank you so much. The comments are coming in. This was really stupendous. And people are actually texting me also. So you're not even seeing some of the comments. So it's pretty awesome. So thank you very much. I really appreciate it. I look forward to seeing you in person. It would be my pleasure again.
Thank you very much. Everybody have a nice day. Thank you.
Bye-bye. Bye. Thanks, Leo.